Νομίζω ότι πρέπει να ξεκινήσουμε και ελπίζω σιγά σιγά να έρθουν και οι υπόλοιποι μέσα στην αίθουσα για να παρακολουθήσουν μια πάρα πολύ ενδιαφέρουσα παρουσίαση. Δεν χρειάζεται να σας κάνω εισαγωγή για τον ομιλητή. Είμαι σίγουρος ότι όλοι το ξέρετε. Ο Λευτέρης ο Μάμουνας για ακόμη μια φορά μας τιμάει με την παρουσία του. Πολύ ενδιαφέρουσα ομιλία. Το τίτλος είναι Multi-Gene Assays, When and Which Ones.
Ευχαριστώ Βασίλη, ευχαριστώ για την πρόσκληση. Πάντα τιμή μου να βρίσκομαι εδώ. Μου επιτρέψτε να την κάνω στα αγγλικά την ομιλία για να γίνει σε ένα χρονικό διάστημα που μπορούμε να την τελειώσουμε. Let me change the settings real quick here. Okay. So we're going to talk about multi-gene assays and with the title When and Which Ones. And you already heard a little bit earlier about EndoPredict, so I'll skip some of that in the essence of time. These are my disclosures. So we all know that breast cancer treatment has evolved over the years with the introduction of important systemic therapies, we're going to talk in a minute, later on as well. And we know that from the overview analysis, data from Richard Pito, that the mortality and locoregional recurrence and distant recurrence rates have significantly decreased from the mid-80s, as you can see here from the UK and the US. But this evolution that has led to significant progress also is at the expense of significant overtreatment. As we cure more and more patients, a lot of the patients that get the therapy don't really need it. So we have to do better to identify the patients that need the treatment and those that do not. And of course, the introduction of molecular subtypes, the intrinsic subtypes by the group of Peru, Sorley and Peru, in 2000 or so, changed that because now we recognize that breast cancer is not one disease but has different subtypes that actually have different prognosis, as you see here, as well as different biology. So with that in mind, as we know, there have been several commercially available genomic classifiers, starting with the first MammaPrint, the 17-gene prognostic index, then the 21-gene recurrence score, and then the breast cancer index, and I will discuss this in a bit, as well as EndoPredict and Prosigna. So these are all commercial assays. Most of them, actually all of them now, can be done in fixed paraffin-embedded tissue. The initial MammaPrint required frozen tissue, but then eventually the assay now is doing in fixed paraffin-embedded tissue. So as we're faced with all these different classifiers, the question that we have to ask as we evaluate them is, first of all, what clinical question does the test answer? Is it a prognosis question? Is it a prediction question? And more importantly, will the test help improve treatment decision-making? I think that's the core of what we're trying to do. What type of information does the test provide? You heard about tests that provide dichotomous or trichotomous results or continuous variables. And perhaps the most important question is, what is the level of evidence behind the test? I think that's an important question. So when you make a prediction, or you make a prognostic prediction or predictive prediction, how confident are you that this prediction is correct? And of course, how practical is the test to use is not an issue anymore because all of these tests can be done now in fixed paraffin-embedded tissue. So all these genomic classifiers have clinical utility in doing a variety of things. Some do more, some do less. But essentially, all of them pretty much predict risk of distant recurrence. That's why they were developed. But of course, some also predict benefit from adjuvant chemotherapy, which is a very important part because that's a decision we need to make. Some predict risk of late recurrence and or benefit from extended endocrine therapy. And some prediction of risk of locoregional recurrence, which I will discuss as well. I won't discuss in this talk prediction of risk of late recurrence and benefit from extended endocrine therapy because we have a session in the afternoon at 5 where I'll discuss this topic, so I'll skip it for this one. So prediction of risk of distant recurrence, of course, as we know, the 70-gene prognostic index was the first one that came to the market based on the work by Laura Van Veer that's published here. 70 genes showing that early metastasis can be prognosticated by the test with a low risk and a high risk. It's a dichotomous test, or at least it was a dichotomous test. Now it's changing a little bit, and we'll talk about that. And of course, this test was put to a prospective trial, as you know, the MINDAC trial, that essentially evaluated this test for patients that have clinically high risk but genomic low risk, as you see on, let me see if I can see the point, as you see over here, those patients were treated with, if clinical and pathological were high, both were low risk, they actually did not receive therapy. If they were high risk, they received chemotherapy. And patients that have discordance between the clinical and the genomic risk were randomized to be treated according to the genomic risk or were treated by the clinical risk. And then the question here was, the main endpoint of the trial was for patients that have 70 gene low risk, but they were clinically high risk and did not receive chemotherapy, that they will do better than 92% 5-year distant metastasis-free survival. So the main purpose of the study and the main endpoint was actually prognostic, and then we'll talk a little bit about that later on in terms of prediction, because they compared the two approaches in terms of prediction. And what they showed, actually, when they presented the result, was that the 5-year distant metastasis-free survival for this group here was 94.7%, even with a high confidence intervals, did not cross 92%. So this trial clearly showed that this is a prognostic test. We'll talk a little bit again later about prediction. And of course, then came the 21-gene recurrence score, as you know, which was validated in the B14 study for patients treated with tamoxifen, low, intermediate, and high risk. But this score statistically was found to be better fitted in a linear relationship, not a dichotomous relationship. So as the score went up, so did the risk of distant recurrence. And of course, this test also was put to a prognostic test. This was the TAILOR-X study that took patients with different recurrence scores under 11, 11 to 25, and over 25. Those that were over 25 got chemotherapy. Those that were under 11 got endocrine therapy alone, and then they followed, and we'll see the results from that. And those that were in the middle, the 11 to 25, were randomized to receive chemotherapy versus not. We'll talk about that later. But again, this study in 2015 showed that for those that had under 11 and had endocrine therapy alone, the test is very prognostic, 99.3 5-year distant relapse-free interval rate. So prognosis is clear for the low-risk patients, as we see here. And further data from this test were also obtained from the SEER data in the US in a large cohort of patients, 55,000 patients. And you can see here for patients with 0 to 10 and even 11 to 17 recurrence score with endocrine therapy alone, no chemotherapy given in these patients, 98.6, 98.1, very, very good prognosis in a large database. And also for those that had micrometastasis or those that had even N1 disease with, again, 0 to 17 scores, the prognosis was excellent. So clearly this test is also very prognostic as well. The breast cancer index, this is a test where it evolved over time. Essentially, it was the H/I ratio, the homeobox 13 interleukin 17B receptor ratio. And then they also introduced molecular grade index, was a 5-gene index, essentially related to proliferation and try to capitulate grade. And when you combine them together, then they got the BCI, which essentially categorized patients to low, intermediate, and high risk. And this is sort of a continuous score as well, but it was validated in additional data set that it is prognostic. And as we'll talk about that later on today, this is also a test that we use for prediction of late recurrence and benefits from extended endocrine therapy. But you can also use it up front if you like. And of course, I won't spend too much time because you already heard the detailed analysis about EndoPredict, the 12-gene assay, RNA-based, and again, combined with the EP, the clinical score, the EP clean. So there is EndoPredict and EndoPredict with clinical score. You heard all the data. This was validated in several of the Austrian ABC, SG, 6, and 8 trials, as well as the TransAttack trial in the low-risk group and the high-risk group. Again, prognostic, no question about it. And finally, the PAM50. Again, this is the risk of recurrence prognostic model, which also incorporates potentially clinical, like subtype model or subtype plus the T-score and subtype plus the T-score and grade, and optimizes the outcome. And even the subtype here, you can see that they're predictive. They can separate into the basal, the HER2 positives, the luminal A, luminal B. And essentially, mostly it's the luminal A patients that actually have low risk. Every other group has at least intermediate to high risk. And again, when you combine it with the clinical factors, there's a continuous score as well. So several of these tests are prognostic. I think there's a little argument about that. But what about the second question? Can we predict risk? Can we predict a benefit from adjuvant chemotherapy? Because that allows us to make a very clinical decision of whether we give chemotherapy or not. And the first evidence of that came from the NSABP B20 study with the recurrence score, as you know. The B20 study compared chemotherapy and tamoxifen to tamoxifen alone for non-negative patients. And when we went back and had the recurrence score and we looked at benefit from chemotherapy, overall the study has shown about a 5% benefit, which was significant, and a lot of patients were treated with chemotherapy because of this study. But when we applied the recurrence score, we saw no benefits in the low recurrence score category, pretty much no benefit in intermediate risk category, and about a quarter of the patients that were a high recurrence score appeared to have pretty much all the benefit from chemotherapy, recurrence score of 31 or greater. So this was for non-negative patients, and then there was another retrospective study, the SOGATE 814, for postmenopausal patients with not positive disease that looked at the recurrence score and essentially showed the same results. No benefit from under 18, no benefit 18 to 30, and benefit in 31 or greater. And with that in mind, this was again put into the prospective trial validation. And this was the TAILOR-X that I showed you before, score of 11 to 25. And why 11 to 25 versus 18 to 30? We shift the cut points a little bit just to be more conservative. We shift them to 11, and then, of course, we shift the other one from 30 to 25 to make it, from 18 to 25 to make it more applicable. And so they were randomized to endocrine therapy alone or chemoendocrine therapy. And this is a large study. Almost 7,000 patients were randomized between the two groups. And as you know, the results showed absolutely no difference in the benefit from chemotherapy between the chemoendocrine therapy and endocrine therapy alone in this invasive disease-free survival as well as distant recurrence-free interval. These results now persist with 12 years of follow-up. I'll show you some data in a minute. But that was the original presentation. So when you then, at the time they presented that data, looked at different groups between 16 to 20 score, remember under 15 or 11 did not get any benefit, up to 15 did not have any benefit, but 16 to 20 and 21 to 25, what we see here, there was benefit for patients with 21 to 25, but it was only in premenopausal patients under 50 years of age with recurrence score against 60 to 20 or 21 to 25. So postmenopausal patients, absolutely no difference, but premenopausal patients had benefit if they had recurrence score of 21 to 25, irrespective of clinical risk, low or high clinical risk. And those 16 to 20 had benefit if they were high clinical risk, but not if they were low clinical risk. And these are the 9-year data, but this data, as you will see, also persists at 12 years. But when you look at according to age in the premenopausal patients, you see that potentially an emerging pattern is that maybe is related to indirect effect on ovarian function suppression. Because when you look at here, patients under the age of 40 that were premenopausal did not receive any benefit from chemotherapy. And then you see 41 to 45, 46 to 50, premenopausal received benefit from chemotherapy. But for 41 to 45, for 46 to 50, if they were premenopausal, there's benefit from chemotherapy, but if they're postmenopausal, there is no benefit from chemotherapy. So you can argue, why did these patients not get any benefit from chemotherapy if it was a direct effect? Because usually those patients will resume their menses even after you give them chemotherapy, so they're still premenopausal. But these patients are likely to become postmenopausal because of chemotherapy. And these patients that are young, but they're already menopausal, don't get any benefit. So that kind of makes sense that the effect may be more an indirect endocrine effect and not a chemotherapy effect. Again, these are the 12-year data from the TAILOR-X showing exactly the same thing. The difference is now a little bit higher. This is for patients with a 21 to 25 and high clinical risk, 11% difference. For 21 to 25 with low clinical risk, there's still about a 6% benefit from chemotherapy. But for those 16 to 20 with high clinical risk, the benefit is now about 3%. So it's a little bit less, and obviously no benefit for low clinical risk for 16 to 25. And again, this is based on a significant number of patients, so the estimates are pretty good. And of course, then after the TAILOR-X, once we did it in non-negative patients, then the other question is, what about no positive patients? So the responder trial took patients with 1 to 3 positive nodes, ER positive, of course, HER2 negative, and if they had a recurrence score result of 0 to 25, they were randomized to endocrine therapy or chemoendocrine therapy. The majority of these patients received tamoxifen as their endocrine therapy, but about 13% had ovarian function suppression and either tamoxifen or an aromatase inhibitor. And the results of the trial essentially showed a little bit of benefit, very small benefit, but initially was statistically significant when they presented San Antonio. When they published it, actually wasn't even significant at p-value of 0.10, and about 1.2% absolute benefit in favor of chemotherapy. But then again, when they looked at it according to menopausal status, postmenopausal patients, their lines are practically superimposable, but premenopausal patients appear to get about a 5% benefit from the addition of chemotherapy. Again, is this a benefit for direct cytotoxic effect, or is this a benefit from indirect endocrine suppression of the ovaries? Again, similar to the TAILOR-X, about 13% of the patients in both studies only had ovarian function suppression. The majority did not. Going to the MINDAX study and looking at MammaPrint in terms of prediction of chemotherapy benefit, again, the discordant cases, the high clinical risk, low genomic, were randomized to be treated according to the clinical risk or the genomic risk, and essentially chemotherapy versus no chemotherapy. And none of the differences were statistically significant here, but for the high clinical and low genomic risk, there was a little bit of a trend in favor of chemotherapy. For the low genomic and high clinical, the low clinical and high genomic risk, you would have expected more chemotherapy benefit, but you don't see at all chemotherapy benefit here. But you do see a little bit of trend here. But this study as well, and I'm putting them now all together, the TAILOR-X, the MINDAX, and the responder, also showed that the benefit of chemotherapy appeared to be in the younger women under the age of 50. So when you look at all of the 3 studies, there was no benefit in postmenopausal, but a significant benefit in premenopausal patients who are under the age of 50. Now, when you look at these genomic classifiers, another indirect effect of chemotherapy benefit will be pathologic complete response after neoadjuvant chemotherapy. And of course, we've seen now several data sets, including with a recurrence score here, both pathologic response and clinical response in the Jenny Cheng trial, and some with the 17 gene index as well as the breast cancer index, showing that in the low end of the genomic classifier, low recurrence score here, low MammaPrint here, and low BCI here, pathologic complete responses are essentially not even there at all, or very, very low. And only in the high end of the recurrence score we see pathologic complete responses, same thing with the MammaPrint. And of course now MammaPrint has 2 categories of high risk, of MP1 and MP2, and MP2 is the one that has actually most of the pathologic complete responses, not so much for MP1. So essentially even MammaPrint becoming more of a 4 different cut points here, 4 groups rather than 2 groups. So the question is, if those low genomic patients don't get pathologic complete responses, where is the effect in the premenopausal patients coming from? And again, we came back to the issue of potential for ovarian function suppression. So why the difference in chemo benefit between age menopause in patients with a low intermediate genomic risk? Again, the hypothesis is that perhaps this is not a cytotoxic effect, but an indirect endocrine effect of ovarian function suppression with chemotherapy. And to address this hypothesis, we actually now have designed and opened a study in the NRG, the so-called NRG BR009 or offset trial. And essentially, we base this trial for the findings from the responder and TAILOR-X. So the patients from responder and TAILOR-X that had benefit from chemotherapy, which are the premenopausal, for the PN0, 16 to 20 with high clinical risk, or 21 to 25 irrespective of clinical risk, or PN1, as in responder with a 0 to 25 recurrence score, they're stratified and randomized to ovarian function suppression plus an aromatase inhibitor, essentially maximizing the endocrine therapy, and then with or without chemotherapy. So this study, hopefully, whenever it's done, which is going to take about 10 years, if it shows no benefit, I think we would have finally, get us to where we need to be, that we use the genomic classifier to predict lack of response to chemotherapy. I think that's an important point, despite of having higher clinical risk sometimes, even with up to 3 positive nodes. Now, an interesting observation that actually supports this notion of indirect endocrine effect is the data that were presented at the ASCO meeting from the respondent trial looking at serum AMH, anti-Müllerian hormone, which is a marker for prediction of residual activity in the ovaries, right? And so, for example, if patients that have low AMH score at the final menstrual period, there was less than 10%, medium was 10 to 99%, and high was over 100%. And when you look at it according to age, what you find here is that for patients under 45, only 2.9% had low AMH. Essentially, they had ovarian reserve. But 45 to 49, about 14% had ovarian reserve, and 50 to 54, only 52% had ovarian reserve. More importantly, when they looked at the effect of chemotherapy according to AMH levels, for patients that have low AMH levels, there were no benefit from chemotherapy. These were essentially younger patients. They took under 55 and look at their AMH. And if the AMH was low, there's no benefit. But if the AMH was high, in other words, they still had ovarian reserve, the benefit was about a 7.8% absolute improvement. So even a better categorization, as in the responder trial, based on the AMH. So I think this is something that we can potentially use now to actually predict if a patient is essentially, even if it's younger and may have some menstrual cycles or very close to the final menstrual cycle, if the AMH is low, there shouldn't be any benefit from chemotherapy. So what about the guidelines? What do the guidelines suggest against the US guidelines, the NCCN guidelines, looking at the postmenopausal and 0 or N1 patients with 1 to 3 hormone receptor positive, HER2 negative, essentially strongly consider the 21 gene assay for patients with tumors over 0.5 centimeters, so T1B and above. And of course, those patients, if they have a low recurrence score, adjuvant endocrine therapy alone. If they have recurrence score over 26 or greater, adjuvant chemotherapy. So this is for postmenopausal with N0 or N1. For premenopausal, though, things get a little bit different. For premenopausal N0, based on the Taylor-X, again, strongly recommend the recurrence score for tumors over 5 millimeters. And then again, the decision is based on what you see, under 15 endocrine therapy with or without ovarian suppression, 16 to 25 chemotherapy, or endocrine therapy, depending, again, and then over 26 chemotherapy because they benefit. And lastly, in the premenopausal with N1 disease, then here we can say we use any of these genomic assays that I mentioned to you for prognosis, but essentially not any of them predicts essentially benefit from chemotherapy, and usually we'll give chemotherapy followed by endocrine therapy, but also they talk about ovarian function suppression, they still as an option. The ASCO guidelines essentially very similar for postmenopausal over 50, again, the Oncotype DX. The mammoprint is indicated for patients with a high clinical risk, not for low clinical risk, and again, not for patients with a premenopausal under 50, and then EndoPredict and Prosigna, again, for postmenopausal patients over the age of 50, but not for the premenopausal patients. And so these are the guidelines, at least for the US. Now, the last topic I'd like to talk about is prediction of risk of locoregional recurrence. Because, of course, we have made significant progress in assessing risk of distant recurrence with genomic classifiers, but when it comes to locoregional recurrence, we still use traditional anatomical pathologic factors such as tumor size, grade, number of positive nodes, lymphovascular invasion. But we also know that risk of local recurrence and distant recurrence are very tightly correlated for patients. It represents the biology of the tumor. So the hypothesis is biology predicts the risk of distant recurrence. Should they also predict risk of locoregional recurrence? And of course, with that in mind, the risk of assessing locoregional recurrence has evolved because now our initial assessment uses clinical and pathologic factors, but we also use molecular subtyping, right? In terms of triple negative, HER2 positive disease, or ER positive, HER2 negative. And once you do that, then I think you can take two paths in assessing risk of locoregional recurrence. For hormone receptor positive, HER2 negative, you can use genomic profiling, and I'll show you the data to support this. at least for assessment of risk of recurrence. Whether it makes a difference in treatment, that's a different question. And of course, for those that triple negative and HER2 positive, we take them to the path of neoadjuvant chemotherapy. And again, based on response to neoadjuvant chemotherapy, we can also predict the risk of locoregional recurrence. And we'll talk a little bit about that in subsequent talk. And some of the ER positive, HER2 negative patients that are high risk can also go through the neoadjuvant chemotherapy pathway as well. So the current available evidence with genomic profile provides considerable insight to tumor biology for sure and this locoregional behavior. However, it's fair to say that at the present time that this has not yet resulted in meaningful changes in how we manage patients. Of course, the question you can ask is, can genomic profiling affect surgical management of the breast or the axilla? And the answer is it does not. We do the same surgery based on anatomic extent. We don't base it on biologic factors. And of course, with neoadjuvant chemotherapy, we can reduce the extent of surgical resection based on response. But in traditional model of surgery first, the genomic profiling has very little effect or influence in the extent of surgical therapy. But on the other side, by individualizing list of locoregional recurrence with genomic classifiers, can we actually tailor locoregional radiotherapy? Can we tailor breast radiotherapy after breast conserving surgery, or can we tailor post-mastectomy original nodal radiotherapy? So let's talk about that first, breast radiotherapy. Well, again, in a study from Dana-Farber a few years ago now, they looked at locoregional recurrence by subtype for patients that have breast conservation and radiotherapy, and they found essentially that patients that have triple negative and HER2 positive disease had a lot more local recurrence in the breast compared to the luminal A and luminal B. And luminal A and luminal B patients had actually very similar rates. Now, that was before anti-HER therapy, and it was also before some of the more modern therapies for triple negative breast cancer. So it's fair to say that these lines have come down now, but nevertheless, it isolated the luminal patients as those that potentially have low risk of in-breast recurrence after surgery first. And of course, we published data with the Oncotype since we had the data from the distal recurrence. We went back and looked at locoregional recurrence, and we did so for patients with tamoxifen or for patients with chemotherapy plus tamoxifen in the NSABP studies. Non-negative patients here, you can see that the recurrence score stratifies this of locoregional recurrence to low, intermediate, and high, even with tamoxifen alone or chemotherapy plus tamoxifen as well. And also in Europe with EndoPredict, the ABCG-A trial showed that the EndoPredict predicted risk of locoregional recurrence. The difference was small here, but again, locoregional free survival 98.6 for EndoPredict low versus 96 with EndoPredict high. And within that study also, they had the randomization between radiotherapy or not. It was like a 4-to-1 randomization. But what essentially this showed was that if you have low EndoPredict score, you still benefit from radiation. If you have high EndoPredict score, you still benefit from radiation, but you do better if you have the low score with radiation. So essentially showing that EndoPredict is prognostic of local recurrence, but not predictive of radiotherapy benefit, which is true also so far even for the Oncotype score. So as a result, there have been now several prospective trials that looked at the effect of omitting radiotherapy. Most of them I will show you today with results. These three first, Lumina, IDEA, and Precision, were single-arm prospective trials where highly selected patients were not given breast radiotherapy. The EXPERT is a randomized trial. We have not seen results yet comparing radiotherapy versus observation. So this is the luminal study that they looked at Ki-67 less than 13.25% for clinical T1 and 0 patients with ER-positive, HER2-negative breast cancer treated with endocrine therapy. And their primary endpoint was in breast recurrence. And they said if we get anything less than 5% that without radiotherapy, that would be good. And they got a 2.3%, and even the confidence intervals did not reach the 5%. So that's very encouraging. Of course, we have followed them for a longer time, but this was the first demonstration these patients can be treated without radiotherapy safely. The IDEA trial took patients 50 to 69, and with the oncotype of 18 or less, and did the same thing prospectively with endocrine therapy, no radiotherapy. And again, when you look at the in-breast event here, 3.3% or 3.6% depending on the age, but very similar. So very good outcomes, again, without radiotherapy in highly selected patients. And the Precision trial used the PAM50 ROR, and again, 50 to 65, a very low rate of in-breast recurrence without radiotherapy. in fact, it was a little bit lower than the contralateral breast cancer. So when you think about it, these patients are at risk of local recurrence, but also at risk of a new primary in the breast. So it's not fair to say our goal is not zero. Our goal is to get it to the same level as contralateral breast cancer. And so far, these studies support that, but again, they're not definitive. In the US also, we're running a large phase 3 trial, the DEBRA trial. Again, very similar oncotype under 18, and then randomization between observation endocrine therapy or breast radiation and endocrine therapy. Large study, 1,670 patients, we're about 1,200 in, so hopefully that study will be done soon. So again, when the results of these studies become available, I think we might be able to then de-escalate in breast radiotherapy for patients that were selected by the genomic classifier. But the question here, all these are prognostic tests, and can we get a predictive test of radiotherapy benefit? And this is what this polar profile essentially trying to do that was presented in San Antonio and eventually published now, JNCI. They looked at this profile as a potential predictor of radiotherapy benefit. So essentially, this is from the Swedish BCG 91RT trial for non-negative patients who received whole breast radiotherapy or not. They developed this classifier, which essentially is a gene expression data in 764 patients. And eventually, they came up with a 16 mRNA-based signature that actually predicted outcomes in terms of, and also benefit from radiotherapy. So this is the results from the Swedish trial. You can see for the low polar signature, there was low risk and no benefit from radiotherapy. In the high signature, there was benefit, a higher risk but significant benefit. This was true for the Princess Margaret study as well as the Scottish Conservation trial. So 3 trials showing essentially the same thing. And then they did a meta-analysis of the 3 trials, again pointing to these results, no benefit and very low risk for the polar low, benefit from radiotherapy. And here, the interaction was statistically significant. So obviously, this needs further validation in prospective trials. We may be able to go back and do it in the DEBRA trial as well when the results become available. But that's very promising in terms of the predictive factor. So last thing, what about post-mastectomy regional nodal radiotherapy? Can we use genomic profiling for that? And again, we know that post-mastectomy patients with any number of positive nodes benefit from radiotherapy. These are the results of the overview analysis. One can argue these are older data, and the rates are pretty high without radiotherapy here. However, even more recent data, for example, for the MA20 study looking at the effect of regional nodal radiotherapy, do see benefit in disease-free survival, and distant disease-free survival, very borderline for overall survival sometimes. And also the EORTC trial, again, the effect of regional nodal radiotherapy after PMRT has shown benefit in distant disease-free survival and overall survival. So the question is, since this has become pretty much the standard for node-positive patients, can we find groups that perhaps don't need regional nodal radiotherapy? Again, going back to some of the oncotype results from the B28, now this was a node-positive trial, patients treated with chemotherapy. Again, very similar results. You can see that it stratifies this of locoregional recurrence. And even according to number of positive nodes, this is interesting because even for a number of 4 or more positive nodes with a low oncotype score, the risk is no different than patients with 1 to 3 positive nodes. So, and this was validated also in other signatures, like in other trials, the ECOG 2197 and the SWOG trial also show the same things with the oncotype DX. So now we have another prospective trial in the US and Canada. This is the Canadian Taylor RT trial that takes patients with 1 to 3 positive nodes and have a low oncotype score of less than 25 and randomize them to regional radiotherapy or no regional radiotherapy. So this is the potential to de-escalate the also radiotherapy for patients with 1 to 3 positive nodes. But again, in this setting, can we develop predictive markers as well? Interestingly, when you go back to the Danish trials, the post-mastectomy trials, the benefit from these trials essentially in terms of locoregional recurrence reduction and survival came from the luminal patients, the ER positive, HER2 negative, or ER positive, HER2 positive. There was less effect of radiotherapy in triple negatives and less effect in HER2 positives. Now, again, that's before anti-HER therapy, so these results may not be applicable today. But nevertheless, we tried to de-escalate in luminal patients where the benefit here was robust, right? So you have to keep that in mind. So the same group actually, now are trying to develop a predictive marker for post-mastectomy radiotherapy benefit. And again, they came up with 7 genes whose transcripts interact with PMRT to modify the hazard of local regional recurrence. And what they essentially found in this test and validation set is that low risk with this new classifier showed no benefit from radiotherapy and very low risk, but high risk for this classifier showed significant benefit from radiotherapy. So again, more validations may be needed for this, but that's the right direction. So, in summary, genomic profile has been established and continues to evolve as a useful tool in the multidisciplinary management of early-stage breast cancer. There have been several commercially available genomic classifiers that independently predict risk of recurrence in non-negative and non-positive patients, and some classifiers also predict benefit from adjuvant chemotherapy, but again, to a varying level of evidence between the tests. Genomic profiling also has emerged as a useful tool for the prediction of risk of local regional recurrence, and now studies are currently evaluating the role of breast and regional nodal radiotherapy for patients with a low genomic score, but it hasn't really yet changed our practice. So with that, thank you very much for your attention, and happy to answer any questions.
Thanks a lot, Terry. Excellent talk. Any burning questions? Thank you very much.
Okay.
Dr. Xapapadakis, would you like to join us?